Thank you. Right. Good afternoon and welcome to the Principles of Exercise Therapy with myself, Dale, and James. And this afternoon, we're going to be going through range of movement. As you can see from the pictures in the diagram, we've used the hip as an example there because you guys are doing AMP1, and we've got a brain stretching there. So we're thinking about range of movement, we're thinking about stretching, we're thinking about how we can record how we measure those particular principles. So moving on, having an IT issue. Here we are. This is our centering slide. It just reminds us about what physiotherapy is and what physiotherapy does. So our profession is healthcare, and as we did this morning, with AMP1, you've got to care. It's important that we put the care in healthcare, and you can see that Wendy was very caring in her approach with Sarah. So we learnt about human anatomy and physiology. We learn about human movement and function. We want to maximize wellness and our patient's potential, minimizing disease and injury, and ultimately solving those real world problems. And as we said before, there's never been a time when the world has needed physio, particularly rehabilitating COVID patients, for example. So what are we going to cover today? Well, there's quite a lot to cover. So we're going to want you to describe exactly what range of movement is. And just like everything in PET, there's some principles around stretching and around range of movement. And then we're going to explore some things about why tissue gets tight, and then describe the stretch reflex, and then coming on to things like plyometrics, which is the stretch shortening cycle, and how we can sort of mess about with those various things. If we look in the literature at the moment, stretching's getting a really hard time with regard to does it decrease injury, and the community is divided about whether it decreases injury, because can anything truly decrease injury? James, what are your thoughts on stretching for your community, and for example running, where we're having too much length in the tissues might be disadvantageous? What are your thoughts there, mate?
Hi, Dale. Yeah, funnily enough, I was speaking to Tim recently about this, because obviously, those of you who know Tim, he's not published on this yet, but this was what he did for his MSc all those years back. So he was basically saying that in terms of the static stretching, is whether it's a bad or a good thing, there's no evidence to say either way. And you're totally right that there is a discussion within physio circles and coaching circles of whether stretching is bad because it doesn't reduce the risk of injuries. But basically, these findings have been based on two main studies that were done way back. And for one of them, I think the main one was that it was Pope et al. In about 2000.
Yeah, I mentioned that later on in the presentation. So good knowledge there, James.
So that was, I won't go into too much detail about it, but basically what they looked at in a nutshell was this study looked at stretching the calves, and then from that they were trying to extrapolate that stretching the calves didn't reduce injury risk for the whole of the lower limb. Well, it's a bit of a stupid inference that it would, isn't it, really? But from that, lots of spin-off discussions have come, and that's where it basically derives from, really. Surprise, surprise, you're not going to find that stretching the calf is going to reduce the risk of all lower limb injuries. It was actually, Dale, that's probably why you're aware of it, it was military recruits, wasn't it?
It wasn't. It wasn't a great study. Will's asked a question. Will, I'm going to give you these references right at the end, but it's important that James and I just have this discussion right early on, because the community, the physio community, is a little bit divided on this one. So I just wanted James's opinion on this, because I know James knows the literature and he deals with a lot of runners, whereas I deal with a different athletic community.
In a nutshell, just as a sort of conclusion to that short spiel that we just had, there's no evidence to say that stretching is bad or is beneficial either. A lot of the stuff that people are talking about and basing their opinions on is on outdated research, which wasn't really fit for purpose anyway. So, like many things, if we're basing our opinions upon poor quality research, we're only going to have a poor quality opinion. So, yeah, in a nutshell, there's simply no evidence to substantiate that stretching is either beneficial or that it's not good at preventing injuries, because none of the research has been able to answer those things. But the reason it's not been able to answer it is because the research simply has not been good enough. It's not up to standard.
Yeah, so this is important that the students, you guys, have an understanding of the literature. And James and I obviously have been reading the literature for a long while, and the community is divided, like I said, about stretching. So I work with a lot of the yoga coaches that coach the Premiership. I'm a yoga instructor, so I'm very pro stretching. So that's my bias. And I know obviously the Premiership invest heavily. All the Premiership for football do yoga, and it has some anecdotal evidence for preventing injury. Obviously, we'll speak to Matt about that, who would be a resident expert. But the debate continues. So thanks for your input on that one, James. I think that was important to start with, bit of debate. Now what we're going to do is go back to the principles of exercise therapy. So there's an acronym that we ask you to remember, and that is A-Sport Billy. Okay, so type in the chat what the A stands for, please, guys. What does the A in A Sport Billy stand for? Fantastic. So, yeah, it is A for adaptation. And with regard to adaptation, this is changes in efficiency with both our motor and our physical elements of fitness. So your body adapts, it either becomes stronger, longer, faster, more fatigue resistant with that adaptation. And then we've got the B. What does the B stand for? No, I've gone for the B. I've switched it round. Yeah, good. Fantastic. Otherwise, it's too easy to remember. Yeah, it's all about behavior change. So I was in clinic with a patient yesterday, and we had a whole discussion around barriers to exercise and trying to get that patient to do more activity. And unless we did some behavior change, the patient wouldn't do the exercises. So part of exercise adherence is also changing attitudes towards behavior. And that's really quite important. James, I'll let you come on this one again as well. When we're doing behavioral change, how much behavioral change with regard to exercise do you do in your clinic with your patients?
Yeah, I mean, I think I'd probably come at that at the point of view of activity modification. So I guess the vast majority of patients I see are the other way inclined. So it's rather than having to encourage them to do exercise, I've got to sometimes encourage them to modify their activities to settle down their injuries, because they're inclined to want to keep pushing. So obviously these are athletes from different disciplines who don't want to stop training because they believe that if they have a couple of weeks off, their fitness levels are going to decrease massively. And so they try and push things, and it's just trying to get their heads around the fact that, if they push things on, they're likely to be struggling with niggle for a long time, whereas if they take some time now to settle down, allow things to desensitize and to strengthen up, and nip it in the bud, they're more likely in the long term to get back to where they want to be much quicker. So still, I think, Dale, we're still talking about behavioural change, but from opposite ends of the scale there.
Yeah, I must admit, normally I'm at your end of the scale, working with athletes as well. But in the sports injury clinic, obviously, we're seeing all and sundry at the moment. So it was just really nice to go back to some basic, why is exercise good for you type of conversation with one of these patients. So yeah, it was interesting. So
Yeah.
Moving on. So thanks for that, James. To the I, what does the I in the Billy of our sport Billy stand for, guys? Type it in the chat, please. Yep, it is exactly that. It's individuality. Okay, knowing that everyone's different, we can't prescribe the same thing for everyone else. And then L, one of the L's. One of the L's of Billy, sport Billy. Okay, so lifestyle what? It's lifestyle integration. Okay, so we're integrating exercise and physical activity into our life. And then the next one that you've mentioned is the law of diminishing returns. That's when we potentially reach the rehabilitation plateau, and that's where better is going to take longer. And then finally, the why of Billy. What does the why of Billy stand for, please, guys? Type it in the chat. It is your responsibility, meaning that you cannot do your exercises for the patient. So you must encourage them to do that themselves, which is good. So we're back to the sports now. And what was S? What was the S in sport, please, guys? It was specificity. Yeah, and that's task specific. So we're giving exercise according to the particular task that we need to do. Good. And then we've got the P. What does the P stand for? Okay, yeah, it is progression and regression. Yeah, progression and regression. Make it harder, make it easier. We've got to find that exercise program that's just right, that where the patient finds what we call their edge, where we're not overtraining them, but we're not undertraining them either. And then we've got O. What's O standing for? Yep, this is the overload principle. Brilliant. And when we've got another acronym that's associated with overload, can anyone remember what it is? There's another acronym associated with overload. Not sure whether we've done this yet. Yet specific adaptation to impose demand. Yep, that's one of them. And then we've developed, it's not police, not fit, not reps, no. Okay, it begins with a D. Have we done it yet? It's drive. Okay, so overload for duration. Then we've got rest. Then we've got intensity, volume, and energy systems. That's a new acronym. I don't think I've introduced that to you yet. I love an acronym, as far as you know. And then we've got the R. What does the R stand for? It is, Jade, straight in there. What does the R stand for, guys? Type it in the chat on sport. What is the R in sport, please? Yep, reversibility. Okay, and that is if you don't use it, you'll lose it. And that's what James's patients are very scared of doing. They're scared of that. If they don't train, then they will suffer the principle of reversibility. And certainly during lockdown, lots of people will be experiencing reversibility, particularly with regard to their strength training. And then finally, the T. What's the T in sport, guys? Timeout. Yeah, okay, that's our rest, recovery. Rest could be sleep, or it could be just active recovery. So all that sort of stuff. Brilliant, guys. It's great to see. So drive is duration. How long does the exercise last for? Rest, intensity, volume, and energy system. Okay, so that's the drive principle, and that's a better version for overload. So just so we understand that. So we're moving on. So here we have the Asport Billy. We've just covered that. It's great to know that you've already digested that and you seem to have a good understanding of that. Can you just give us a thumbs up in the chat if you're happy with those principles? Most of you were all over that. Yeah, fantastic. Brilliant, brilliant, brilliant. Okay, so we understand those principles. So let's move on to today's lecture and what we're talking about. So what we're talking about really is range of movement, and we're talking about really range of movement over a specific joint or body part. That could be the posterior chain, for example. And then we're talking about distance, which could be linear or angular. We remember that from our biomechanics lecture. That a movable object may travel while attached to another, i.e. Effectively, the joint is attached to each other. So we're measuring the distance and direction of the joint moving. So for example, how many degrees of flexion at the knee? So if we use the case study from this morning, how many degrees of flexion in Sarah's knee reproduced the pain that she was experiencing? How much extension with someone with a meniscal injury? How much extension have they got at the knee, for example? And then we're thinking about the therapeutic effect of stretching, elongating the muscle tissue, and then range of motion therapy is what we're doing today as well. So we're trying to effectively lengthen tissue or improve the quality of the tissue so that we're able to get a physiological response in terms of increased movement within the tissue. So how are we going to measure it? When you are a salty sea dog in the world of physiotherapy, people like James and I, we can generally just eyeball stuff. And we know roughly how many degrees of flexion, or how, an active straight leg raise, for example, we know what 60 degrees is, we know what 45 is, we know what 90 is, we know what 120 is, because we're so used to doing that. But when you are new in your physio career, please, please, please use a goniometer. So the goniometer, as you've used already, is fantastic for making sure that you're using an objective measure. So outcome measures and objective measures are massively important, because if you're not assessing, you're guessing. And if you're not good enough to guess, then you might be getting that wrong. The other things that you might want to think about are things like tape measures. Tape measures are great for example, doing a knee to wall test, for example. How many centimeters away from the wall does the foot need to be so that the knee can still touch? So we've got these three different ways of doing it. We can just eyeball, have a look. Does left equal right? Are they roughly symmetrical? If not, we might investigate with either an outcome measure, such as a goniometer, or a tape measure. So they're the ways that we effectively make the subjective objective. So what happens when we stretch? So we want muscle fibers lengthening, okay? And this is, so the muscle is called the sarcomere, and the sarcomere is elongating. So there is such thing as strength training when you can get sarcomeres in series, which is one after the other, or sarcomeres in parallel. So sarcomeres in parallel, muscle units in parallel, when the muscle gets bigger, that's hypertrophy. And sarcomeres in series is more where we're doing some eccentric, so lengthening under load, muscle contractions. So you can build muscle from stretching, but it will be under an eccentric load, and we cover that a little bit later. So we're talking about things like areas of overlap. We're talking about muscle fibers reaching their maximal length. We're talking about the forces being supplied or applied to these tissues. And then we're talking about things like the direction of the collagen. So collagen tends to line up in the way that the tissue is pulling. So this is why things like stretching a muscle when you've come out of, I don't know, a plaster of Paris, you've had, for example, an ankle fracture, the bone has healed, but all the tissue is going to be super tight. Stretching that tissue will pull the collagen in the direction that you want to reinforce the collagen strength. So that's what happens when we stretch. So imagine we have a muscle. So when we've got muscles, we tend to think about the extrafusal fibers. These are the sarcome, the muscle fiber itself that the actin and myosin and all that other stuff that we cover in muscle physiology later on this semester. And then we've got the intrafusal fibers, and these contain a muscle spindle. And the muscle spindle does several things. So the muscle spindle is basically sensing the stretch in the muscle. And it's going to stop you from overstretching. And it's also going to have a sort of proprioceptive effect of knowing where your body is in space. So that's a really good example of that. So if you just get your elbow and then just bring your fingers to touch your shoulder, your bicep will contract. You'll feel that contraction of the bicep. Okay, and then as you elongate, okay, you'll feel stretching of the bicep. And it's the muscle spindle that's allowing the brain to know that that's happening. So we've got different tissue types within the body. So some are going to respond to things like immobilization, i.e. being in a plaster of Paris, waiting for the bone to heal in different ways. And we've got both elastic and plastic changes that happen to the tissue. So when we're talking about tissue, we're going to talk about two things, the collagen fibers and the elastin fibers. So collagen, these are highly resistant to deformation, and they give strength and stiffness. And they don't have a huge amount of elongation. Yeah. So we're looking. So for example, the Achilles. We need the Achilles to be quite stiff and strong. The Achilles is the strongest tendon in the body. So we need to make sure that is capable of taking huge loads. It needs to be strong and it needs to be stiff. Then we've got the elastin fibers, and these give extensibility, and these elongate easily at low load, and they have a huge elongation. They can go up to 150% of their length. And the behavior of these tissues depends on the proportion and the orientation of these fibers. So it's important that we understand a little bit of physiology before we go on. So we're regularly going to encounter limitations of movement, and that might be with a neurological patient that has spasticity or hypertonicity in, for instance, the upper limb. And we're also going to be working with tissues that are tight and tissues that are potentially short and tight, and potentially tissues that are loose and weak. And then some of the common problems that we get are things like contractures, and that happens in the joint capsule. We get adhesions in the soft tissue and the fascia. We get muscle spasm and tightness. So, for example, in order to protect the spinal cord, the muscles will spasm and lock the spine in place. And then after the spinal insult has resolved, you might still have that muscle spasm and tightness unless it's treated. This can go on for a long period of time. So I had a patient yesterday whose original back insult had resolved, but they still had lots and lots of muscle spasm and tightness around the back that then became the problem. And then we've got also things like neural or nerve sensitivity. We've got things like pain inhibition. So you'll come across all these terms in AMP1. It's just something that we need to be aware of. So in order for a joint to be healthy, it needs to have full range of movement that is pain-free. So going back to a couple of weeks ago when we did proprioception in week 5, we've got these mechanisms that help us know where our body is in space, and they're going to detect, control, and respond to changes in their physical displacement, in tension, in force, and in pressure. Okay, so that's the tissue is aligned, it responds to these various forces. So here we have an example of a muscle stretching, or a muscle being stretched, and that stimulates the muscle spindles. That's then going to have an effect in the spinal cord. Now, depending on what's going on, this might be dealt at spinal cord level, or it might actually go up all the way to the brain if there's a threat. So the information is processed as a motor nerve. Okay, James, can you, like Lisa's answering quite a complicated question there. If you could deal with that, that would be great. And then we've got activation of the motor neuron, and then we've got the muscle contracting according to the stimulus as well. So we've got to understand that the muscle contracts as part of a spinal cord reflex, and that might go actually all the way up to the brain as well. So proprioception has got 3 mechanisms that we're dealing with, and we've also got something called mechanoreception. Okay, when we're feeling changes in the mechanical properties of what's going on. For example, this will be the muscle spindles that we've just been talking about in the muscle fibers. We've also got the Golgi tendon, and that is found within the tendon at the junction between the muscle and the bone. There will be some tendinous apparatus, and then we've also got things like Pacinian corpuscles, and these are also within the tension, within the tendon, but they're also in the skin, and they sense pressure effectively. So that's what they're doing there. So if we deep dive into what's going on, so here you can see we've got the tendon, and tendons do what, guys? What? Just type in the chat. What's the function of a tendon? Tell me what the function of a tendon is, please. Attaches muscle to bone. Excellent. Okay, you guys are all over this. Okay, so we've got the tendon that then becomes the muscle, and at the tendon, the junction between the tendon and the muscle, we've got the Golgi tendon organ, which is a way of sensing what's going on and regarding to the force generation of the muscle. Okay, so this is where it gets a little bit complicated. So for example, if you were doing, I don't know, a bench press, and you're getting to your last repetition, but your muscles are fatigued, okay, the Golgi tendon would probably kick in and not allow you to complete that last rep for fear of tearing the muscle. And then this will also feed in to what we call the governor of motor recruitment, which is ultimately the brain. So we can override these protective mechanisms in the body, and we'll show you how a little bit later. But it's just understanding what's going on at the muscle and at the tendon. And like I said, the Golgi tendon is more about measuring of force of the muscle, and the muscle spindle is more about the stretch, but they're all about a protective mechanism of the body. So as we're saying here, okay, we've got things that are happening. The Golgi tendon is measuring force generation of the muscle. Okay, we might be doing a rapid contraction, a power movement, or we might be doing a strength movement that takes maximum motor recruitment. That's going to go to the spinal cord, and then the spinal cord is going to then change what's happening to the muscle. The muscle might relax or it might contract more depending on what the body needs. So it's just understanding that we've got a bit of a spinal reflex going on there. Then we move on to the Pacinian corpuscles. Okay, these are found within the body. Okay, and they are effectively sensing where we've got compression, and these will respond to elongation, indentation, and they are important to know about. We also talk about the muscle spindle and the Golgi tendon, but just be aware of Pacinian corpuscles, okay, as they're measuring potentially things like the pain pressure threshold, which is really important for potentially when stretching becomes painful. We don't want stretching to be painful. So we can artificially stimulate this stretch, this myotatic reflex. And this is where we use the tendon hammer. Okay, so for example, if we were to strike the tendon of the knee, we can get a muscle contraction in the quads as the hamstrings relax. Effectively, what we're doing is we're just overriding the normal process of what goes on through the spinal cord, and we're stretching the muscle externally. So it's important that we just have an idea that the stretch reflex is also related to things like range of movements. So here we're just really covering the same thing, making sure, I know we haven't done the muscle physiology lecture yet, so it should be a little bit clearer when we do that. So remember that the muscle that's being stretched will cause contraction of the, so you can stretch a muscle by contraction of the agonist, and then you get relaxation of the antagonist. And this is also, as we've highlighted before, to do with the sensory input of what's going on proprioceptively in the muscle. So here we're doing a hamstring stretch. We can feel what's going on, and if that stretch is too much, okay, it will actually go to the brain and signal that there's something dangerous going on. Okay, so normally it will just happen in the spine, okay, and we get some local information. But if you are overstretching, particularly things like the hamstring, that might go to the brain first, okay, to signal that there's a threat or a danger. But sometimes we've got things like the withdrawal reflex. So if you put your hand on something hot, you'll naturally withdraw, okay, and then you will register the pain later. So the body's got all these protective mechanisms that are absolutely fantastic. Okay, just thumbs up in the chat if you've ever put your hand on something and then automatically you've pulled your hand away. Anyone had that experience? Yeah. And your brain wasn't conscious of it. Okay, you'd already pulled your hand away. Okay, and that's thanks to the senses in the body. And then you'll normally feel the pain later. So if you'd waited till you'd felt the pain, okay, then chances are you'd have injured your hand far more doing that. So what I want you to do now is think about what is the stretch reflex and how could we use this in terms of exercise. What are the different ways that we could use the stretch reflex for exercise? So we're going to go into our breakout rooms because I know you love a breakout room, and we're going to discuss this. So what is the stretch reflex? Making sure that we're clear on this, okay, and how could we potentially use this for exercise? So I'm going to put you in your breakout rooms, guys. Okay, so everybody happy with the task? Just discussing with each other, what is the stretch reflex? What have we just covered? Talking to each other so that we understand what's going on with the stretch reflex, and then thinking about how could we use the stretch reflex for for exercise. What exercises are involved with the stretch reflex? Okay, so you're going to go into your breakout rooms now, and James and I will be coming round, just having a little chat, seeing what's going on. So into your breakout rooms now, guys. Hello, James. Hi, James. Are you there, my friend?
Sorry, mate, I was talking then, but I didn't realise that I was still muted. Yeah, so we've got 10 groups. Should I just take 1 to 5 and you go?
We do the same thing again as well, just getting them a bit of interaction. They're much better at the breakout rooms now, so it should be fairly easy. If you do 1 to 5, and I'll do 10 down to 6. Okay.
Okay, yeah. See you
Right.
soon.
Thanks, pal.
Okay.